Thanks to AIOS for this virtually fantastic show, and thanks to Dr. Somshila for the invitation. So I'm going to continue exactly where Aditya has left and tell you my personal do's and don'ts in this tricky site-saving procedure. Are my slides seen?
Yeah, we can definitely.
So general anesthesia is usually preferable for therapeutic penetrating keratoplasty because the eye is inflamed, the patient has discomfort, may not cooperate. There may be new events happening during the surgery and upthrust may be there. COVID clearance is important for general anesthesia because eye is important, but life is more important for the surgeon as well as the patient. The tricky thing about diabetic control in therapeutic PK is that sometimes you're waiting for clearance for sugar to get control, but the infection in the eye, however small it may be, is preventing sugar control. So that has to be kept in mind and a compromise arrived at. Patch for corneal perforation is these days not indicated because the lid can move and it displays more structures. But just before the surgery, if it is local anesthesia, I like to put a small patch with space for the block around so that the block does not dislodge intraocular contents immediately. Mannitol can be given to shrink the vitreous preoperatively, but the patient should be instructed to void urine to avoid a full bladder, which can be counterproductive. Simple sedation sometimes can cause a bizarre movement of the patient and should be avoided. However, drugs like dexmedetomidine in skilled anesthetic hands can work almost like general anesthesia. Exposure is very important to eradicate the infection. A universal eye speculum is preferred over a wire speculum. The Fleringa ring, which supports the globe, can also be used to thread a suture, which can then work like a rectus to position the eye. And sometimes when the infection is very extensive, we can use traction sutures at opposing ends of the limbus and rotate the globe down. The case in point here is a rhinosporidosis infection, which has caused a scleral melt, and the globe has been rotated down with traction sutures to expose the area of interest. Sometimes in infiltrates, which are limbus to limbus, suturing can be difficult. The conjunctiva needs to be opened up. Otherwise, if we suture over the conjunctiva, when the edema subsides in the postoperative period, the sutures can become loose. When we do this conjunctival opening, as you can see in the picture below, severe bleeding can ensue because it is an inflamed eye. So firm pressure with or without adrenaline on a gauze is the best way to control this bleeding because too much of cautery is both frustrating and can cause limbal ischemia. So in the panel above, you can see a large infiltrate which possibly needs a large graft. But on table, when the AC was washed, you can see that the infiltrate is left back. The solid part of the hypopyon is left back. All the fluff got washed off and we can size the graft properly now. And the slit photo on the side shows an area of thinning inferiorly, which is not obvious on the diffuse illumination. So this has to be encompassed to prevent wound leaks in the postoperative period. So when there is a corneal perforation, the iris rushes forward. That is a protective mechanism. And you can see in my beautiful artwork below that normally the iris is horizontal, but during perforation, the iris bows forward to kind of cover the perforation. So this has to be remembered to trephine without damage. And like Aditya said, you have to make careful grating entries so that you don't go through and through the iris and injure the crystalline lens. So this is the most important slide in this presentation, showing the first part where the iris needs to be cleaned up of exudates, as shown in the video earlier. We remove the entire infection, but this little remnant can cause a recurrence. Damaged portions of the iris have to be removed, but good portions have to be retained to avoid postoperative glare. The angle has to be washed thoroughly so that zippering does not cause angle closure. And large PIs need to be made to avoid pupillary block in the postoperative period. So this is the golden triad of therapeutic PK. So some tips are when you have an infection that is resolved, which has led to staphyloma, still you need to operate on this eye because there is an intermittent leak in the central area. And when it seals, the IOP increases to form a staphyloma. So you cannot glue this because the cornea around is unhealthy. But temporary glue can be applied so that the anterior chamber can be entered a little more comfortably. And the corneal graft itself can also encompass a scleral frill, which can then be used to cover the staphylomatous area, of course, after de-epithelizing it first. When the infection has formed an anterior staphyloma, as you can see in the panel on this side, one other small trick is to adopt a hand over hand or a protected PK technique, where you put in the graft first and then slowly you remove the host cornea. This may cause endothelial damage, but in a large staphyloma, it is worth doing it to prevent an expulsive hemorrhage. The operating microscope gives us a wonderful opportunity to look beyond the ulcer itself. Here, we took it up as a limbus to limbus infiltrate, but you can see under the lid a large mound of sclera. We thought it was necrosis, but we opened and we found scleral pus. So that changed the game plan of the treatment entirely. And foreign bodies and vitreous involvement have to be looked for in post-injurious corneal ulcers. Everything is against the epithelium healing in a TPK because the quality of tissue that we use leaves the epithelium sometimes in shreds, and inflammation prevents the healing. So many sutures are being used. Toxic medication needs to be continued post-operatively. And an epithelial defect not only can cause recurrence of the infection, but can set up a new infection also. Treatment with amniotic membrane graft is not very useful because in these inflamed eyes, the graft breaks up almost immediately. So case in point over here is during the pandemic times, a glycerin graft that we have used for TPK. These work very well, but these acellular grafts is really difficult to get them to epithelialize. So we have used a small tarsorrhaphy and punctal occlusion, and in the picture below, you can see that the graft is healing very nicely. Sometimes when the infection extends up to the limbus, as you can see in this panel of pictures, then TPK can also be followed by a recurrence. So what we did at SN is that we cross-linked the donor cornea itself, as in TPK1, TPK-CXL1, and we extended this further by doing the cross-linking after the TPK to involve the graft as well as the graftose junction, TPK-CXL2. TPK-CXL1 gave enough tensile strength to the donor cornea to prevent recurrence, and TPK-CXL2 not only consolidated the strength, it also sterilized any residual infection. So a combination of these two, we saw reduce the rate of recurrence in large ulcers, and we have reported the same. So this video shows mostly what Aditya shows, but incorporating a few of my favorite steps. So last but not the least, it should be remembered that the main aim of TPK is not to have a clear graft or a good refractive outcome. So before rushing in to give steroids or doing early suture removal, we must remember that the main aim of this surgery is to salvage the eye. For indeed, we should be able to save the eye to impart good vision to the patient. Thank you so much.